Hello everyone and welcome back to Desert Docs, a junior doctor's guide to Central Australia. This is a series all about the unique medicine and working life that comes with operating in Alice Springs and the greater Barkly region, whether that be Alice Springs Hospital or in primary care, which is what we'll focus on today. So first I'd like to acknowledge the lands on which this podcast is recorded. Desert Docs acknowledges the Aranda people of Mantua. We recognise their custodianship and their continuing relationship with country, and that we work on their stolen lands. My name is Dr. Indira Barrow, a second-year junior doctor based at Alice Springs Hospital. Today I have Dr. Fiona Pringle as my guest. She's a rural generalist based in Alice Springs.
I live in Alice Springs. I practice in two communities primarily, which is Nyirripi. It's about 500 k's northwest of Alice Springs, and Amunturrngu, which is otherwise known as Mount Liebig. It's about 350 k's northwest
North
of
as well.
Yeah.
So that's a pretty long way to get to work, Dr. Fiona Pringle. So I have seen some lovely images of you on a small plane. Is that a normal life for a rural generalist?
It is for me. We've got quite a team of rural generalists, and depending on where we are practising, so some of the rural generalists, I'll just call them RGs from now on, work on in community clinics which have a sealed road to Alice Springs, and usually it'll be somewhere between 3 and 4 hours drive. Because the drive to the clinics where I work is much longer and the roads are very poor and much worse after rain, of course, often impassable, I fly to work every week. So my Monday morning commute is being picked up at 7 a.m. and transported to Tjoritja or NTAS, which are the charter airline bases in Alice Springs. And I fly usually in a Cessna 402 an hour or an hour and a half to work. Stay for a few days, 3 to 4 days on the community, and then fly back on either Wednesday or Thursday afternoons. It's great.
Sounds like you'd get a good view up there, and the skies are always blue here, so I imagine you would have not much turbulence and some stunning views.
Well, that's winter flying is like that. However, coming back in the afternoon when the dry heat, there are lots of whirlwinds and that develop, and so it's actually quite challenging. It's very rough. And as you come over the Tjoritja, which is the main range that passes through Alice Springs, it's often you've got to hold on to your seat.
And is it you and a pilot? Are there any other patients? Are there any other passengers on the flight with you?
Yeah. It's often just myself and the pilot. But coming back from community, we make a big effort to gather people that might have appointments in town, and they quite like flying. And it means also we can stay with them because it can be quite scary for people to come into town, into Alice Springs. And so they travel with me and will often travel in the same transport to their accommodation or to Alice Springs Hospital. Yeah.
And Fiona, how long have you been in Central Australia working in either the remote clinics or in Alice Springs?
I first came to work here, I think around 10 or 11 years ago, and I worked for Congress, and I was at clinics where I drove and then stayed on community, and I did some locums, some longer, of a number of months. And in fact, for one of those early times, my son, who was 11, came and went to school as well. So spent a term at the school, and then my husband and other son came out. I was covering Christmas, New Year, so came out for the Christmas holidays as well. So yeah, that was pretty special.
And Fiona, were you already working as a general practitioner before you came to Central Australia?
Yes, I'd worked for about 15 years as an urban GP, and I decided I'd always wanted to work in Central Australia. I was aware that culture here was quite strong, and my parents were involved with the Lutheran Church actually, and knew a lot about Hermannsburg in Dari. And So I was quite familiar with the history. And my father was also, he was a teacher and became a senior public servant, and was very interested in Aboriginal education. And I guess we kind of absorbed that as we grew up. So it was kind of something that I had thought about a lot.
And did you have to do any retraining to work as a general practitioner here? How was that transition in coming here?
Interesting, because there was no requirement on me to do any retraining, and I started off working for Congress, which is the main Aboriginal-led medical primary care service in Alice Springs, and working in town. Those skills could be translated with some knowledge about Aboriginal health and the difference in working with Aboriginal people, and some cultural training. But my wish was to go. Actually, I was asked by an Aboriginal woman who I'd been to some singing workshops, and she was a very spectacular child health nurse at Indari, and said to me, "Why don't you come and work on our community?" I think at the time they didn't have a doctor, and I was at the singing workshop. And I thought, gee, I'd love to do that, but I would be very scary not having many emergency skills as an urban GP. So I started on the path of acquiring lots of emergency management skills, initially through the college. I'm a fellow of the Royal Australian College of General Practice. And then I worked during COVID, actually a little bit later on, I worked for 18 months in the emergency department in Newcastle, and those skills really stood me in good stead. And that was also my pathway to becoming a rural generalist.
I think that's part of the excitement and probably a large source of fear being a rural general practitioner or a rural generalist, being faced in a low resource setting without help nearby with anything that comes through the door. Would you be able to speak to some of the experiences, dramatic or normal or routine, that you have working out in the rural, in the remote clinics where you work?
Well, you are a solo medical practitioner, but that doesn't mean you're not surrounded by support. And that's the thing that you don't quite realise until you're working in community. So first of all, especially when I first started, and I must say it's quite tragic, there's a significant problem with having enough nurses in remote communities who stay. And most of our community clinics are staffed by agency nurses. But even 10 years ago, it was very different. There were a lot of Aboriginal health practitioners who are very experienced, and a lot of often end-of-career nurses who had had lots of ED, ICU experience, and they're your support. You're part of a team. And that team also extends to Alice Springs. So when I first started, there was what was called a DMS, and that was a senior doctor on the phone from whom you could ask advice and whom you needed to contact if you thought somebody will need a medical evacuation. And that's changed over the years, and now MRAC, the Medical Retrieval and Consultation Service, gives everybody on community clinics a lot of support. Many of the clinics even have video cameras, so the person who is helping from the MRAC Nerve Centre, which is above the ASH-ED, can see the patient as well, and there's a back and forth conversation. And there's always this saying that we've said, that RGs and people in remote clinics say, if you're in trouble, phone a friend. And, you've got lots of people to support you. Yeah, it's not nearly so scary. And the other thing that I think is really interesting is that the more emergency training you do, there's a limited amount you can do with what you have on community clinics. So it simply, things become very simple in your mind, that you just address what you can, which is, go through the A, B, C, D, E, F, G, and you learn to manage a lot. There's most of the important formulary, most of the important drugs that you need are available. There's also CARPA, so you have lots of protocols to follow. But the simple thing is just keeping somebody alive, airway, breathing, circulation. It's actually the more you do, the more you realise it boils down to the simple things. And then medications, of course. But
Sounds like you're doing a crit care stream within doing your normal general practice in RG. So, Fiona, is there a particular case that has struck a chord with you that would be a good representation of exactly what that experience is like?
Well, a couple of things come to mind. One is a little child, a 9-month-old. The mother comes in with the child and just saying, oh, very sick, not feeding. And we sort of took one look at this little child and they were very limp and struggling to breathe, and quickly found out that they were highly febrile, 39.8, and we could barely count the resp rate, but well above 70, and pulse rate was also difficult to count. And one of the tricks I found is with a little child, especially a frail child, you can get the Doppler ultrasound that you might use on a pregnant woman. You could put it on the child's chest and it'll count for you, because the SATS monitor is hopeless. But that's one of the things that can aid. You put a stethoscope on and you're flat out counting that pulse rate. So we very quickly applied some oxygen and gave the child. They were just well enough to take some Panadol and Nurofen, so we gave both. And I put some MLR on and just waited about 10 minutes, managed to get a cannula in, and we looked at our sepsis protocol and we just calmed the child. And I examined the chest and it was clear to me they had a pneumonia, a community-acquired pneumonia. They also had pus coming out of their ears, and when we looked at the file, this was a child that had had anemia, failure to or growth faltering, we call it now, failure to thrive, had some neglect, and was a client of territory families, what other people might know as DOCS or Department of Child Services. So a complex sort of background with an immediate problem. Luckily, with what we did initially, we gave some antibiotics and we immediately spoke to one of the fellows of I just call them FACEMs, the emergency physicians in MRAT, and they said, yep, we've got a plane, we'll have a plane in the air shortly. And we gave some fluids, and the child did settle in their RUSE, which is what we use to describe severity, which is remote early warning score, came down from about 9 or 10 down to about 4 or 5. And the child looked better, more comfortable, and actually managed to feed a little bit from the breast as well. So we were feeling more comfortable. But then we got a call back to say, sorry, the RFDS plane has been diverted for somebody who's having a STEMI, and we know there's also a preterm birth sort of in the wings, and it might be a little while till we can get a plane to you. So I decided I'd stay around, which is the good thing about being an RG is mostly you're required to work Monday to Friday. And while we might put in some big hours on weekdays, we usually have evenings and weekends off, and it's very comfortable. But occasionally when there's somebody very sick, we will put ourselves on call and stay with somebody who's very sick. On this occasion, I had 2 very experienced nurses, and we stabilised the little one. I stayed for a few hours, and they said, oh, we need you back in clinic tomorrow because we'll probably now be waiting up with this child until the flight arrives. So I went home and said, just call me if they get worse. And I believe the plane arrived about 2 a.m. that morning. So it was substantial time for somebody we were quite worried about.
I can imagine the pressure in that situation would have felt enormous because you're waiting until you can get things like x-rays and further assessment, bloods, for example. Were you working with any bloods at that point?
So we were working with some bloods. We have point-of-care tests, what we call the iStat, so we can get like a venous blood gas result. We can get some electrolytes, and we know the haemoglobin, those sorts of things. No x-rays. Often we might have ultrasound, depends on the clinic. I sometimes carry an ultrasound, a portable one with me, but travelling on plane, it can be a bit tricky because you're limited to 15 kilos, which is your clothes for the week, your food, and then when you want to bring medical equipment as well, they kind of frown and say, don't know whether we can take that this time. But yeah, there's no x-ray. And you tend to rely a lot on, it's good to have very good clinical skills, so
Not relying on investigations and using this very well-honed clinical exam signs, I'm sure. So that sounds like a really good example of an emergency, and there would be other routine things you see in the clinic. So what kind of smorgasbord or spectrum of clinical presentations would you see in a day?
It depends. Some of the clinics are quite big, and we'd often have a number of children who are sick, gastroenteritis, chronic suppurative otitis media, acute otitis media. Pregnant women and children are a big focus of mine, because I think if you have a healthy childhood, you're much more likely to be a healthy adult, so starting early. So children, pregnant women come in for their antenatal checks or not. Young people often avoid the clinic, but we do screening on every Aboriginal person every year, if we can find them. I think the other thing that might be surprising to people is how transient Aboriginal people are. So they might live in one community, but they only might spend 3 or 4 months a year in that community. They might be travelling to see relatives or to attend funerals, which they call sorry business, which can be a prolonged process of many months sometimes. So people move around a lot. So it's not always easy. You know, somebody's got a health check due and not always easy to find them. But with young people, we're always on the lookout for STIs, getting onto that quickly. And then there's just the everyday business of general practice. People have injuries, have back pain, but then there's a lot of chronic disease. And the chronic disease management is a big part of my job. So people have hypertension, they're smokers, they have diabetes, they have chronic kidney disease, and it often happens very early. And as a result of that, people have quite high cardiovascular risk, and people having acute myocardial infarcts and strokes on community is quite common. So that's another common acute presentation. But it's a real mix of acute and chronic disease management.
Just diverting from the clinical things for a second, you mentioned sorry business. And I remember one of my first experiences of the Northern Territory up in Nhulunbuy was going to a funeral and seeing the traditional dance of the Yolngu people. Have there been any experiences that you've had working in community that you've been privy to that you think have made working out here so special?
Yes, I think you are given an insight into how important family and community are. I once had when I was a junior doctor, I worked at Prince of Wales Hospital in Sydney, and the cultural officer there said, when she was giving cultural education, she would say, look, I can't tell you about every culture, but I can say that there are really 2 types of culture in the world. There's the me culture, epitomised by US nuclear family type way of living, and there's the we culture, which is actually most of the world. And I would say that Aboriginal people are the absolute epitome of we culture, and events of joy and sadness are shared by a huge number of people, and there are many traditions around those events. And if I could share something personal, I lost my young brother early in my adult life, and I was part of a Lebanese community at the time. My first husband was Lebanese. And I witnessed and was enveloped by the Lebanese way of grieving, which was to gather and just to sit and talk. So the whole house would be cleared out and there would just be chairs, and the food would come and go, and people would just sit and talk for weeks on end. And you see that, and from a personal experience, I felt really supported and enveloped, and the sadness is kind of shared. And I see that to some extent from the outside, I might say, when I see Aboriginal people mourning and attending to sorry business. There are people go and live all together in what they call sorry camp, and sometimes for a number of months, and talk or not talk, and have traditions around that. And for instance, that can last for a while, and then there's what they call the finishing up, and that will be how the person's possessions are dealt with and how the places where they used to frequent are dealt with. So, for instance, the family of that person won't live in the house for at least 12 months, and somebody else will move into that house. And then there are lots of traditions around smoking ceremonies, which are around many events, but particularly around death.
Mm.
And clinics are regularly, if somebody has passed away in clinic, then the clinic will be smoked as well and sung. And often little bouquets of flowers might be put around the clinic gates it's quite lovely actually.
When I was in Tennant Creek, I heard from some of the cultural awareness teachers there who were local Warramungu women that saying someone's name is not necessarily done after they pass away. And one person asked me whether Indigenous people in Central Australia are happy to be filmed and videoed. I think if we're not in these locations, sometimes based on movies and videos, we think that images of Indigenous people can't be seen after they pass away. But there is a bit of a nuanced difference here. But I see that the names are still something that has a time of not being said.
That's right.
In recognition.
And I always wondered, when you go to community particularly, people have these amazing names. Their first names are often biblical names and names that are compound names of other names. And I thought, why are these names so complex and different? There's no Marys or Joes, or they're Jebediah and Sherilyn and like complex names like that. And part of the reason I've been told is that they don't want to be named after somebody else. So a new name has to be chosen each time a child is born. Yeah, so they're not named after somebody who's passed.
Wow. Oh, I didn't know that. That's interesting. Yeah. Fiona, if we can talk about how someone who's in a junior doctor position might move through the medical system to find their way into a position like yours, which is a rural generalist. For you, that process seemed to be horizontal. You were already a GP and then came here and picked up some emergency skills, some cultural awareness and understanding and experience. If you know that's something you want to do from a junior doctor level, how might someone go about that?
Well, I guess there's one thing I would say about Alice Springs, which is that the integration of different medical practitioners is really a very well-worn path. So everybody knows each other and people cross over different. So some of the anaesthetists in town are also our part-time RGs. Some of the MRAC doctors are RGs rather than FACEMs. And so there's a lot of crossways pathing. People make different paths from themselves in a way and often work part-time in two completely different jobs. But as a junior doctor, there's really two main pathways because there's two GP colleges. So there's ACRM, which is in a way focused more on rural and remote work and regional work, and every ACRM fellow is an RG. So because during their training they incorporate special areas, including there's quite a large component of emergency medicine. But you can then also choose a special area, which might be anaesthetics or obstetrics, and you would be the person who is delivering babies or giving anaesthetics in a regional or remote or regional hospital. The bigger college is the RACGP, and there used to be a program called the FAR GP program, and that's now changed into the Fellow of the College as well as a Rural Generalist fellowship, so it's a sort of double fellowship. But you can actually identify that you're wanting to take that path right from the very beginning of your general practice training with the RACGP as well. And it usually involves an extra year or two and working in some specialist areas and examined in some specialist areas.
The other thing I wanted to tease out was with you working in such and you said you're well supported in Nyirripi and Mount Liebig in the remote clinics. Do you have registrars come through? Do you have interns? So I'm based at Alice Springs Hospital at the moment. Is there an avenue for me to come and spend time as a junior in these clinics, in these remote settings?
Absolutely, yes. So there's a new program where the junior doctors can do one term with attached to the Rural Generalist. They often move to different clinics, but yes, so I've had 2 junior doctors with me over the last few weeks, and it's fantastic. It's fantastic for me as well, but they've both really enjoyed the program, yes. And I think that's largely due to the integration in Central Australia. So the medical director of Central Australia Primary Health is also the Director of Education for Junior Doctors at Alice Springs Hospital. So there's kind of a lot of crossover.
A lot of networking and oversight.
There is.
Yeah.
And one of the benefits for us has been as RGs, last year, one of the FASMs devoted some time to training us. So we spent every fortnight doing 2 hours of SIMS at Alice Springs Hospital on a Friday afternoon. And SIMS are a fantastic way to feel comfortable with emergencies because it becomes almost routine. You just know, this fortnight I'm going to manage preterm birth and a STEMI and this, and hey, I've done it in a sim, so what's so different? You know, all of the pathways, all of the ways you think become just second nature, and it's great.
It's nice to think that will be a automatic reflex one day, because it's still very stressful when things like that happen at my level. My last question, Fiona, is about what you love in terms of outside of work experiences about being in Central Australia, and why here is so special and unlike anywhere else in Australia.
It is unlike anywhere else. I think the first thing is just the proximity to people who have such strong culture that is so different from my experience. And there's just a richness about that. And to be honest, people are very warm. I call people clients, but the people, the patients that come to the clinics, as they get to know you, they're very keen to share their language. The kids love to teach you language. Their traditions to take you to places that are special to them. For instance, when I worked at Nooka, and one of the female elders, I was keen to go to Numbulwar, and I said, I'm thinking I'd like to drive to Numbulwar, will that be okay? And she said, oh yes, I'll come with you. I want to go and see family at Numbulwar. So I spent a weekend with her showing me all the special places along the road. And interestingly, she told me, so it's about an hour's drive along a dirt road, that they used to walk back and forwards, and she showed me all the landmarks for where they would know they were on the right path, and all the billabongs and places to get fresh water. So yeah, people share a lot with you. That's at work. On my time off, I love to go camping. There's some permanent water holes, and I'm a cyclist, and there's plenty of cycleways. There's lots of, opportunities for sport. There's a huge inclusivity around the people that live in Alice Springs. They're quite used to people coming and going for a short periods of time, for a year or 2 or 3, and they were once often the newcomers, so they're very inviting, and just whatever sport you play, there'll be a group. There's a public book club at the local Red Kangaroo bookshop you can join. There's sewing groups, there's anything you can think of. There's walking groups. There's lots of good cafes. There's the cultural centre and lots of culture activities. So for 9 months of the year, Alice Springs has the most amazing weather. Clear blue skies, cool at night, somewhere between 20 and 30 during the day of dry warmth, and it's just beautiful. I have discovered that I don't like spending a whole summer here, but that's another story. But I would say people think it's hot, and it's hot for the summer months, but for the rest of the year it's absolutely beautiful. So you can get out in nature. There's plant groups, and there's the Araluen Centre, which during the winter, during what we call the tourist months, there's a large activity on at Araluen. So it might be the Australian Ballet, it might be a musical comes to town, because most of the theatre and singing people, ballet, dancing, they come to Alice Springs on part of their Australian tour, and it's often the last place. And the performers often are really keen to come here because it is special for them. But yes, Bangarra Dance Theatre will come once or twice a year. There'll be art exhibitions. There'll be all sorts of cultural activities.
And live music, a fair bit of live music as well.
Lots of live music. There are visiting musicians, but there's also an enormous amount of musical talent around town. And I don't quite understand why, but there's just musicians thick on the ground.
I think everyone has a lot more time on their hands here and they can really invest in their hobbies or find new hobbies, and that's definitely been the case for me as well, working as a junior doctor at Alice Springs Hospital.
Yeah, spend a lot less time commuting.
That's right. You can bike ride to work as well. Thank you so much, Fiona, for coming on Desert Docs, a junior doctor's guide to Central Australia. I've really enjoyed chatting to you about what it's like working outside of Alice Springs, as I haven't been out that way much yet. Is there anything else you'd like to say before we turn off the microphones?
Oh, just come out and experience it, and perhaps you'll really love it. A lot of people come here and they think, oh, I'll just stay for a year or so, and then they tell you they've been here for 20 years. Anyway, it's an experience for everybody, short or long.
That's right. Thank you so much, Fiona. Desert Docs, a junior doctor's guide to Central Australia, is an anti-health media podcast produced with the help of ACCC Studio.